Good afternoon, everybody. Thank you for joining us for the American Association for the Surgery of Trauma virtual grand rounds today. Pelvic Mayhem, Navigating IR, OR, REBOA, and more in unstable fractures. This event is hosted by the Associate Member Council of the AAST. A little bit of housekeeping. Please note the AAST no longer offers CME for live grand rounds. Should the archived version of this grand rounds have CME, those of you who registered for today's webinar will receive an email to log into the AAST website and claim that CME. I'm going to start off by introducing all of our esteemed speakers, and we're very thankful to have all three of them today. Dr. Scalea is the physician-in-chief at the R. Adams Kelly Shock Trauma Center and the Francis X. Kelly Distinguished Professor in Trauma Surgery. He is heavily involved in American Board of Surgery, ACS Committee on Trauma, numerous editorial and review boards, and all the major national and international trauma groups, including, of course, the AAST, in addition to holding numerous grants for research. He is an active educator, winning many awards for his teaching and leadership, and we're very privileged to hear from him today. Dr. Todd Costantini is a professor in surgery and the chief of the Division of Critical Care and Acute Care Surgery, as well as the vice chair for clinical quality at the University of Minnesota. He is an NIH-funded researcher working to understand inflammatory pathways after injury and has published extensively in optimizing VTE prophylaxis. Germane to our discussion today, he is an expert on complex pelvic fracture management and hemorrhage control strategies with numerous high-quality publications on this topic, and we're thrilled that he's joined us today. Finally, Dr. McCauley is the trauma medical director and assistant professor of surgery at the University Medical Center at Texas Tech Lubbock Health Sciences Center. She completed her residency at the University Medical Center in Lubbock, followed by a fellowship in surgical critical care and trauma at UT Houston Memorial Hermann Hospital and the Red Dew Trauma Institute in 2021. She's heavily involved in the North Texas ACS and the North Texas Committee on Trauma and has a particular interest in strengthening trauma systems and regionalization of trauma care in West Texas. She recently gave a fantastic grand rounds at my institution, Parkland, and we're tremendously excited to hear about her expertise on the challenges of rural trauma care, particularly prolonged transport times in the care of our complex pelvic fracture patients. So with that, we will get started with Dr. Costantini, focusing on trauma-based management of these difficult injuries. Thank you.
All right, great. Thank you so much for the opportunity. I'm excited to be here today and contribute to this panel. So my initial charge is to talk a little bit about the initial management of hemorrhage control for patients with pelvic fracture. So broadly, we'll talk a little bit about taking care of the basics and then decision-making about where you should go next. Start with a case presentation. 43-year-old male, motorcycle crash at fairly high speed, is hypotensive in the field, heart rate of 130s, comes into your trauma bay and has the x-ray that you see there. Now, what we know pretty clearly from multi-center studies over the past couple decades now is that these patients have very high mortality, and this really hasn't changed over the past several decades, and is reflected in each of these multi-center studies, with mortality in patients with pelvic fracture and shock nearing about 30%. We learned a couple, I think, important things from this. The first is that there's significant variability in how different centers manage trauma patients that come in with hemorrhage and potentially shock. And I think that variability maybe represents an opportunity to do things maybe better or differently. I think the other thing we notice is that most centers use a very angioembolization heavy approach for pelvic fractures with hemorrhage. And I think that's obviously right in some places, but maybe not all. And the use of REBOA and pelvic packing is still lagging in a majority of centers across the country. So when you have a patient who comes in with this pelvic fracture pattern that's sick, you need to be ready and you need to have an organized approach because the clock is ticking and time matters, which means to start, you need to take care of the basics. And by basics, I mean, think about placing a pelvic binder when the patient comes into your resuscitation room. A T-pod binder is shown here. This is important for open pelvic fractures to decrease the volume. It's a simple, quick intervention. After you place the binder, you should get another pelvic x-ray to make sure that it's actually worked, that you've applied appropriately and have achieved the goal you want, as you see on the right side of the screen here. Damage control resuscitation is also critically important. Many of these patients with appropriate resuscitation will stop bleeding and may not even need advanced hemorrhage control interventions. And so just a reminder of what this means. First, minimize crystalloid. Secondly, make sure you call for blood early and activate the massive transfusion protocol as needed. And that means in many places, whole blood up front and then one-to-one transfusion. Don't forget about replacing calcium, potentially giving TXA, and then check a tag and decide whether or not the patient can benefit from adjuncts like cryoprecipitate. But again, mobilizing this early and not waiting for the patient to have prolonged hypotension is critical for these patients to do well. As you all probably know, there's different pelvic fracture patterns, which are shown here by the young Burgess. And one of the questions that was posed was, should all patients get a pelvic binder, or should we be worried in certain pelvic fracture patterns? Clearly, patients with the open book pelvis, the APC 2 or 3 pelvic fractures, benefit from the most from pelvic binders and should absolutely have those placed. Theoretically, there are some fracture patterns where a binder placement could actually make hemorrhage worse by opening the posterior elements. But I think, when in doubt, and if there is some open component to the pelvic fracture, open meaning fracture pattern and not an open wound, I think it's advisable to put the binder on early, and when in doubt, use it aggressively, because I think it does make a difference. And this may be something that we'll chat later about in our discussion. The other thing that's really important that can be forgotten is to look for open pelvic fractures, meaning an open wound that is bleeding. If you don't look in the perineum, and look for open wounds, you may miss them and may find a large amount of bleeding on the bed under the patient. These have some of the highest mortalities of all pelvic fracture patients. You must pack these promptly and make sure that you prevent ongoing external decompression of that hemorrhage into the outside world. So when you're standing there in the trauma bay, you've gotten your pelvis X-ray, you've diagnosed them with a pelvic fracture. They have hemodynamic instability. You need to address quickly 2 very important questions. The first, are there other sources of bleeding? And then the second is, where should I go to control that bleeding? And what's the best route for the patient? I think that is the decision that often has a significant impact on patient outcomes. So the first is look for hemorrhage. It's important to remember that patients with severe pelvic fracture patterns also have injuries in other body cavities. So evaluating the chest and specifically the abdomen. I think this is a good study that showed that we can rely on our FAST in patients who have pelvic fracture and we're concerned for pelvic bleeding, and may direct us where we go next for care of this patient. But at the end of the day, it's location, 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 right? You're standing in the trauma bay, and most of our centers, you're going to take the patient to different geographic locations with different resources, depending on what hemorrhage control modality you're going to use. The general options are external fixation, angioembolization, preperitoneal packing, or REBOA as an adjunct to temporize and get patients potentially from point A to point B. Here's one example of a pelvic fracture management algorithm. And you can see sort of broadly dividing into hemodynamically unstable and stable fractures. I think, getting into the hemodynamic unstable side of the algorithm leaves some degree of subjectivity, right? Patients aren't unstable until they're unstable, and you don't want to find that out in the CT scanner or someplace where you don't have the resources that you need for hemorrhage control. So you need to be thoughtful about the patient's clinical status. I think if patients are unstable in many centers, they belong probably not waiting for the angioembolization suite and for interventional radiology to care for those patients, and may do better with a REBOA as a temporizing measure or going directly to the operating room for pelvic packing. Of course, that decision might be made even easier if there is evidence or concern for intraperitoneal hemorrhage as well. REBOA is an important adjunct. It's probably underused in many centers. Here's a good study from Malika Harfouch and her colleagues looking at the use of REBOA in the zone 3 position. It's again important to also remember it's usually REBOA and something else, right? Some other hemorrhage control intervention, but REBOA may be a good way to decrease hemorrhage, decrease transfusion requirements, and get patients to a destination for their next hemorrhage control procedure. Because in the end, it's time that matters. This is a study from USC several years ago now, which in pelvic fracture patient looked at the effects of time on mortality, finding that every hour that you increase time to pelvic angioembolization significantly increases mortality. And you say, well, of course, in my center, I can get to angioembolization very quickly and certainly less than an hour. It's never a problem. But the truth is that's not always true, right? And this is a study done from UT Houston where they compared their daytime access to their evening and weekend access to interventional radiology. So you need to think about what your resource mobilization looks like, because it may not be as fast as you think, and it may not be the same depending on the time that you need to get your interventional radiologists and their team into the hospital to perform these procedures. So that's led some to think about aggressive use of pelvic packing. This is a study from the Denver group who deploys really a pelvic packing first approach where patients get transfused. If they still have evidence of hemodynamic instability or ongoing hemorrhage, they go directly for pelvic packing. In this study, they compared their single institution study with a multi-center study looking at sort of a random or highly variable pelvic hemorrhage control and found that their mortality was better than sort of the historic numbers. I think probably not a fair comparison, but does give you the idea that this may be a good approach, and certainly to me highlights the fact that you need to select your patients correctly. And if they're bleeding and having significant transfusion requirements, the OR might be the best place for them where they can get the best resuscitation and the best hemorrhage control with pelvic packing, even if that is a means of waiting for the interventional radiologist to come for embolization. Of course, people are interested in trying to compare, is pelvic packing better than angioembolization? And I think, this was in the most recent AAST multi-center study, this was sort of the attempt to answer that question. And we found that it's really difficult. And it's really difficult because they're end up being two very different patient populations. So in this study, they found that patients who got pelvic packing did worse and had higher mortality compared to the other groups. But when you dig into this data, these patients are a lot sicker. They have much more profound shock and much severe injury. So it's really comparing apples and oranges to try to make this comparison. And I don't think we can do that appropriately to really decide if one is better than the other sort of in all-comer patients. With that, I'm going to stop and I'm going to turn it over to, I believe, Dr. Scalea for the next talk.
Yes, we're going to have Dr. Scalea, who will be speaking about intraoperative decision-making, pearls, and pitfalls.
You guys see my slides okay?
Yes.
Looks great.
Yes. Let's see if I can break the computer. I am not able to advance my slides.
Okay, while Dr. Scalea is getting his slides ready, I just want to remind people, if there are any questions, please enter them in the Q&A, please.
There are a number of decisions that I think are important to make, and principles here is that you work where you work. You should have this figured out before it's 3 in the morning. You mobilize your resources early. And one of my favorite expressions is that critical care is a concept, not a location. Be expansive. When I do a laparotomy in a patient with a pelvic fracture, I always keep the laparotomy incision above the umbilicus. I look at the size. I almost never open the retroperitoneal hematoma. Intraperitoneal packing, as far as I'm concerned, violates every principle of packing, and I don't think it's a very good strategy. I use liberal use of damage control. The number of true rapidly expanding hematomas is really small. In the operating room, in the TRU, still the most important thing to do is to reduce the bones, and then you can see various options for pelvic hemostasis in the operating room. External fixators are talked about, but they almost never help. They're either not needed because the fracture is already reduced, or they displace the posterior fracture fragments. A C-clamp is actually what you want, and it's what we use almost always. Or just leave the binder on, move it down, and you'll have access to the groins. When I do extraperitoneal pelvic packing, which is not very often, if I combine it with a laparotomy, I almost always use a fatted steel. I raise some flaps, I split the muscles vertically, I divide the rectus transversely if I have to. They all get a hernia, I fix them later. Denver uses 3 laps on every side. On each side, I use whatever stops the bleeding. There's sort of the schematic. There's a shot from Clay Cawthron, 3 laps on each side. And I think pelvic packing is a relatively morbid procedure. This is their original data. It's a 15% incidence of infection. Some had reasons, but half of the people had no reasons. And if you have to repack, the rate of infection is really quite high. This is the first patient I ever packed, and it's still how I do things. It's actually one of my faculty members, and she had a grade 4.5 right lobe of the liver injury and bleeding from her pelvis as well. It's kind of how it looks. Hypogastric ligation is a thing. This is a meta-analysis, about 80% successful. I don't think 80% is great. And I think it's also morbid. This is about hypogastric embolization, proximal hypogastric embolization, data from our shop. And there's really a prohibitive risk of deep space infection if you take the entire vasculature to the pelvis, and then they need an operation to stabilize. There is a thing called intraoperative hypogastric embolization, first described in Denver in '87. You can see what they make a slurry out of. And then they ligate the hypogastric artery, pull it up, access it, and put 30 or 40 cc's directly in. I've never done it. It's an option. And as Todd said, when you really come right down to it, what do people do? They embolize the pelvis. That's what really happens in American trauma centers. This is Malika Harfouch's data. And this is us in 2015 or so, AAST, and we weren't very good. Mean time to embolization, 5 hours. People say it's an hour, but it's not. And a lot of death from early uncontrolled hemorrhage. And the issue is time here, right? It's about time to definitive hemostasis. The clock starts ticking at the time the patient arrives, not when you get to the angio suite. And I can't think of a lonelier place at 2 a.m. with a patient that's actively bleeding than angiography. The radiology guys are technically quite good, but they don't really understand trauma. So now you've got to put a senior member over there to kind of babysit the procedure. I don't get it. REBOA is a great thing because it buys time. It's great in the TRU. We put a bunch of them in the operating room. In pelvic fractures, it actually achieves inflow control, just where it ought to go. There's no visceral ischemia. You can keep it inflated. And it probably helps venous bleeding by reducing inflow. One of our early publications, about 30% of patients then had a negative pelvic angiogram. This is the problem with REBOA. Only 4 institutions in the country put in 1 per month. Now, you can't tell me if you're putting in 1 a year that this is really an effective strategy for you. And so for us, REBOA is a thing. I put 2 in last Thursday. Hadn't done it in a while, then 1 day. And so if you're really going to use it, it has to be part of what you do. This is us in 2015. It turned out that interventional radiology was 1.5 city blocks away from the TRU. That's a terrible thing because death begins in X-ray. The hybrid room was a game changer. It's an operating room with anesthesiologists and a staff that are used to taking care of sick people. You can do a bunch of things without moving the patient. I don't think CTA is a very good screening test. Diagnostic angiogram is what you need to use to diagnose pelvic vascular injury. You can combine it with the C-clamp. SI screws could be an issue. It does require negotiating with orthopedics. But the biggest lesson here, to quote Top Gun Maverick, is that it's the pilot, not the plane. And meet our first two pilots, that's Megan Brenner and Melanie Hain. And when you have triple boarded surgeons doing your intervention, you've got people that know trauma and know how to plug holes in blood vessels. And this allowed us to knock off almost 2 hours in the time to get pelvic hemostasis. Here are just a couple of cases. A terrible crush injury to the pelvis. There's the zone 3 REBOA. The patient had no recordable blood pressure, goes up to 100. If you think I don't work, you're wrong. That's me putting the REBOA in. And we did this in a pure hybrid way. Open, the bifurcation, the iliac bifurcation's gone. We stacked a bunch of coils and then did an open bypass because the external iliac was sheared off of the bifurcation. There he is on post-op day 16. Not so bad. I only explore the pelvic hematoma for one indication, and that's for major vascular injury. And those are people that are missing a femoral pulse on one side. They have an internal hemipelvectomy on X-ray. This is almost always like the last one you saw. It's injury at the junction of the iliacs. The proximal hypogastric is sheared off. The common is out. And I start from the right side. I mobilize the right colon. I come across the small bowel mesentery. This is what we used to do when we actually did open aortic surgery. You ligate, you control the distal aorta, you go down both iliacs, and you can get to the bifurcation on both sides. Here's another patient that came in with an internal hemipelvectomy, direct to the OR, missing a femoral pulse, and we have shunted the iliac arteries and the iliac artery and the iliac vein. Now, trying to get pelvic stability is important, and our go-to is not external fixation. It's emergent percutaneous SI screws. They stabilize the posterior pelvis. If we do a laparotomy, particularly for a GI injury, we don't plate the pelvis. We use an external fixator as definitive fixation for the anterior pelvis. And then we do delayed acetabular reconstruction as soon as the physiology allows. So my way to do this, it's laparotomy in any patient that has concern for an intra-abdominal mesenteric injury, which you don't always see on CT, particularly with a lateral compression pelvic fracture pattern. I do them all in the hybrid room. We use damage control. We do diagnostic angiography regardless of the CT findings. We use the zone 3 REBOA. And if we pack a pelvis twice in a year, it's a busy year for us. I think if you could get to the angio suite, we're in 20 minutes, and you have the assets to support the patient, angiographic embolization and fracture fixation is the way to go. That's how we do it in Baltimore.
Thank you, Dr. Scalea. We can move on now back to Dr. Costantini for a discussion of some of the nuances of concomitant injuries.
All right. Thank you. I'm going to try to share my screen again here. And you guys see okay? Good? Okay. Well, tough act to follow, but I will do my best. My charge in this section of our webinar is really just to talk about some kind of challenging issues or maybe controversial considerations. And so I'll show some data. I'll just preface this by saying I don't think the data is great, but things that you at least need to think about when you're going to deploy things like pelvic packing, how you're going to manage bladder injuries, and when you're going to decide to operate on the patient. So, I think Dr. Scalea mentioned it nicely, which is, pelvic packing is not without potential for issues. In this study, they were looking at, so obviously you pack the pelvis, you leave the packs in for some amount of time. What's the risk of infection? And this is certainly important not only for deep space infection, but also you're going to put hardware in most of these patients to fix the pelvic fracture. So in this study done by the Denver group, they sort of concluded that there was not an increased risk of at least surgical site infection. So they compared patients with preperitoneal pelvic packing versus those that didn't, both undergoing pelvic fixation. They really found no difference except in a subpopulation that had associated acetabular fractures, but asked the question, what about long-term outcomes and how did that affect hardware and the potential for hardware infections? So this was followed up by another study which looked at factors associated with sort of deep space pelvic infection, where they found there was some delayed evidence of surgical site infection, but most frequently associated with repacking the pelvis. So I think this is important to think about the question, you've packed a patient's pelvis. When do you go back? Should you go back and take the packs out and repack it in a routine fashion in 24 hours, 48 hours, like we might do for an open abdomen? And I think the answer is no. The infection rate in a repacked pelvis is really very high. So keep the initial packs in, do your hemostatic resuscitation, try to do any other hemorrhage control. And when the bleeding is controlled, try to get the packs out and close after that, because packing, again, seems to cause problems. The other area that I think is interesting is looking at the effect of preperitoneal packing on VTE. So you can imagine putting a lot of pressure on the pelvic veins and sort of in that general area could have issues with another risk factor for developing VTE. Again, a controversial topic. This, again, a single center study looking at patients treated with preperitoneal pelvic packing, finding a really pretty high DVT rate of 23%, which is higher than we would expect, a PE rate of 8% as well, suggesting that these are sick patients. They're certainly at high risk for VTE, but maybe this is an even higher risk group. Again, single center study here. This was followed up by the clot study group. So this was a large prospectively collected data, 17 centers, looking at only patients 18 to 40 years of age, but a fair number of them. And this data set was used to look at VTE rates based on different pelvic hemorrhage control interventions, and found really no significant difference in the groups and no difference on multivariate analysis. In crude numbers, it was a little higher, but you see a 9% VTE rate in pelvic packing, which was much different than that single center study. So I don't know that the question is definitively answered. I think it's certainly still a relatively safe procedure in the right patient. And then the last, again, is jumping back to the idea of surgical site infection. So again, what happens down the road after you fix these folks' pelvis with hardware? In this study, once again from the Denver group, looking at patients who had open pelvic bony fixation after packing, finding a delayed presence of pelvic space infections. And this was increased with anterior pelvic ORAF. So I think a little bit the jury is out a little. You see some conflicting data. I think we would all probably just organically understand that if you're going to have an open wound in the pelvis, you're going to be taking packs in and out and then putting hardware in, that certainly would be a risk for maybe some increased infection. However, getting hemorrhage control is critical, and if doing the packing to get that done is needed, I think it's an appropriate thing to do. The next question that I just want to sort of bring up and consider is the idea of how to manage an extraperitoneal bladder injury in a patient with a severe pelvic fracture. So classically, patients with extraperitoneal bladder injuries undergo catheter drainage, usually for some number of weeks, and these injuries heal and the catheter can be removed. I think the question comes into play is what happens if you're going to do an anterior pelvic fixation in that patient. So maybe you've had some bladder injury, you've had urine spillage into that space. Now you need to open that space up to put in your pelvic fixation. Many will repair those operatively at the time of pelvic fixation to try to control that. This was a multi-center study done by a mix of trauma surgeons and urologists, looking at 157 patients who had 323 bladder injuries. 43% of these patients with extraperitoneal bladder injuries underwent surgically repaired. And one of the most common reasons was doing it at a time of pelvic fixation due to the concern for pelvic hardware infection. They ultimately found no difference in complications between catheter drainage and surgical repair, so it was a safe and reasonable thing to do. I can't tell you whether or not it alters the infection rate, but again, it does stand to reason, and if you're in that space to fixate the pelvis, it may be reasonable. I think it is reasonable to think about repairing those extraperitoneal bladder injuries at that time. And then the last is how do you decide when to perform definitive fixation of pelvic fractures? You've had a patient who comes in shock, they get hemorrhage control interventions, they stabilize and get better. When should they be fixed? So there's been studies looking at very early pelvic fixation within 24 hours. Those patients have no improved benefit versus those after 24 hours. I think the key is making sure that you first addressed other major injuries, make sure that they're fully resuscitated and that things like coagulopathy have improved. Because as we know, these pelvic reconstructions can obviously be quite timely and have quite significant blood loss. So I think this is a really important area where you have to discuss with your orthopedic colleagues and understand what their operative plan is, what's the duration, and understand that it's not a true emergency to get the pelvic fixation done. Various temporizing measures and external fixers can be used until the patient is fully resuscitated and ready to undergo another big operation. Again, another area we can talk about in the discussion and see if others have differing opinions. With that, I will stop there.
Thank you so much, Dr. Costantini. Next, we'll have Dr. McCauley talk to us about rural and prolonged transport time, pearls and pitfalls. And for everybody that had just joined in prior to this announcement, we have a Q&A session. So any questions and stuff, please enter into them.
Okay. Okay, can everyone see my screen okay?
Looks great.
Alrighty. Yeah. Perfect. Alrighty, well, Dr. Costantini, Dr. Scalea, it's an honor to be on this panel with you. Thank you for your insights. I'm gonna switch gears and talk about pelvic trauma and hemorrhage as it pertains to the rural trauma patients and how we can best take care of those patients in critical access hospitals and then in the tertiary trauma centers. I don't have any disclosures. I'm at Texas Tech UMC in Lubbock. It's one of the most rural level 1 trauma centers in the country, and we cover a very large region across West Texas and eastern New Mexico, and we service over 30 critical access level 4, level 3 hospitals that rely on us for trauma, EGS, and burn care. Although our regional population is about 3 million, Lubbock is about 325,000, which makes for a very interesting breakdown in trauma volume, where 50% of our trauma patients are transferred in. And actually, most of our scene calls are also from very far away, outside of Lubbock County, with an average transfer distance of about 112 miles. And on a given call day, we're accepting transfers from all over the region, level 3s, level 4s, critical access hospitals that you can see there. And many of these patients that are coming from far away have shock indexes over 1.2, some approaching 2. And these represent patients that would likely require whole blood and hemorrhage control, but the variable of time is not on their side. This is the kind of pelvic fracture that we've been mostly talking about in this talk. The hemorrhaging APC3 injury. But the reality is we also deal with this. When you combine Texas highway speeds with Texas farm fences and signposts, we encounter these sorts of impalements a few times a year. And our orthopedic colleagues turn this magically somehow into this. So the variable is time to hemorrhage control, time to blood. And this is the reason that rural trauma patients have a 69% increase in mortality rates compared to urban, and are 14% more likely to die within 24 hours compared to urban environments as well. And we know from studies like the Terry study that for every minute delay to blood, there's a substantial increase both in 30-day and 24-hour mortality, and that surviving is directly related to how fast blood is started. And that those that get the greatest benefits of starting blood and TXA early are those that are going to have prolonged transport times is greater than 20 minutes. And that's every single one of our trauma patients coming to us both as transfers and as distant scene calls. So fortunately, there's a lot of focus on this at the national and COT level, and huge initiatives to get whole blood to EMS units in rural communities. And we have to think creatively, you know, outside the box. Currently, we're in the early phases of using drones to deliver whole blood to our austere environment, but we got to get blood to these patients. So the kind of transfer call we may get is from a level 4 trauma center, 4 hours by ground if they were going to take it, MVC, hemorrhagic shock, pelvic instability, you know, an open book, pelvic fracture on x-ray, fast may be negative if they do a fast, you know, acidotic, acute blood loss anemia, and hopefully they've placed 2 large bore IVs. Oftentimes they're giving crystalloid, and that's after they've given their only unit of 1 PRBC. And the question they'll ask us is, hey, we obviously don't have IR, trauma surgery, orthopedic surgery, or any more blood. We've run out, and I got a patient in hemorrhagic shock. Can we transfer? And what else do you want us to do? And the best thing you can start with in this setting is to immediately accept these patients. The answer is yes on the phone, on the transfer line. Remembering that the variable that you can help with is time. And if you start with the yes, then transportation can start to be arranged in the background if it hasn't already. The other thing is to be cognizant of the challenges that different forms of transportation in these types of rural regions face. Weather is frequently a problem. We have major issues with wind, dust storms, where rotor and fixed wings are frequently grounded. And sometimes the fastest form of transportation may indeed be by ground, even if they're far away, but we got to do something. And sometimes we have to get creative and send our EMS Fox trucks, which do have whole blood on them in Lubbock, and meet rural EMS units halfway on the highway and give them whole blood. These are the kinds of challenges we face. So being there for your colleagues over the phone at those centers is important to brainstorm. What else? So when you have these APC fractures, we've already talked about, the most important maneuver you can do at these outside centers is to make sure there's an appropriately placed pelvic binder tightly at the greater trochanters, repeating the x-ray to make sure that the pubic symphyses are closed down. Also, it's helpful to bind the feet using Coban or Curlex as well to bring things together. If you need a visual, David can provide one here. Oftentimes we get pelvic binders that are placed a little too high, and it's always lower than you think across the trochanters. What else? So venous access is key, making sure that these patients have 2 large bore IVs. Don't underestimate the value of an IO as well. And don't waste time on central venous lines at these outside hospitals. I'm often telling folks at the critical access hospital, they're telling me, oh, we're putting in a central line. And I tell them, stop, put in 2 IOs and get the patient going, get them here. And what about resuscitation? So if rural hospitals have the ability to give balanced blood product resuscitation, that's great. But better yet, whole blood, as we've talked about. Patients bleeding whole blood deserve whole blood. And I'm very proud of our whole blood program at our level 1 trauma center. Our EMS, first of all, our EMS units carry whole blood, but then our trauma patients receive up to 8 units of whole blood before receiving a single component. We have 2 units of whole blood that comes to every level 1 trauma bay. And then our MTP cooler, the first cooler, has 6 units. You know, where it's needed is the pre-hospital setting. And fortunately, that'll soon be a reality in Texas with the amazing efforts of the GTAC pre-hospital whole blood initiative, making sure that whole blood is getting to rural EMS units in the racks. Remember your TXA, and your calcium with your blood resuscitation. Those are all important things. And if they can send blood, if they have any additional blood units at their centers, then they should send it with the transport team. What else? Imaging. So at the outside hospitals, pelvic x-ray always before and after the binder. Fast exam, yes, if they have an ultrasound and if they have that skill set. An accurately performed fast exam in the pre-hospital or outside hospital setting is a golden ticket to the OR when they arrive, especially with a pelvic fracture and hemodynamic instability. So that's going to help me when they arrive if I already know they have a positive fast. What about CT scan? Only if the patient is stable and only if they have surgical or IR capability, which in most cases they don't. I'm often telling them, do not delay transfer for CT. You already have an x-ray that shows what we need. If they do get a CT, I want them to get a CT with IV contrast and then be able to send the imaging. And that will allow us, if they do have one, to pre-plan for OR or IR. What if there is a surgeon available? This is where preperitoneal packing may be valuable. If the patient's unstable or a transient responder, despite a pelvic binder, balanced resuscitation if it exists, and no other major bleeding source identified, to strongly consider preperitoneal packing there if that capability exists there, especially if the transfer time is going to be prolonged and the patient's not going to tolerate transfer. So some packing pearls we talked about, staying extraperitoneal, entering the space of Ritzius. That hematoma is going to guide that dissection, and packing deeply along the pelvic brim to compress those venous plexuses, and to not forget to close the fascia over it to help with that compression. A common pitfall that we encounter when we accept these patients is that we find packing only anterior to the bladder within the space of Ritzius, which is not going to tamponade that bleeding. We saw this image before, the 6 packs. It's what the CT scan should look like if you get one later on, packing deep. Unfortunately, sometimes we get CT scans or packs that look like this, a pre-bladder packing. And this may have happened because of just inaccurate approach, but also in some cases, maybe the patient really didn't need it and that plane really hadn't been developed. But this is not uncommon, unfortunately, to get from our level 3 centers. One pearl that I like to do personally is for those 6 packs that are going way back there, to wrap those laps in Ioban, which helps for when you pull those laps out, at least the ones that are super deep, to prevent it from ripping off the venous plexus. Then you can pack with regular laps on top. We've been spending this talk talking about the nuances of managing these patients. In general, the WT algorithm is a great one to refer to. Of course, there are nuances, and we're discussing how every center is different. So then the issue is expediting care on arrival. So we've talked about getting the patient to the center, to the trauma center, but what else can we do to shave off time? So pre-arrival communication with our orthopedic and IR and OR colleagues is key, especially if we know that there's extravasation on a CT scan that's already been obtained. Calling IR ahead of time is going to help get well under that 1 hour poke time that we need. Also, if you know that patient is so unstable that you might have to place a REBOA, plus minus take them for preperitoneal packing, letting the OR know and getting things prepared, and letting ortho know so they can join you for an X-fix. Communication is going to really help. If you do REBOA, then preparing those materials to have them available. One option is making sure also that your hospital has a solid direct to OR protocol and everything that's involved in that. Ours is called Flyby, where we make a rapid assessment pre-hospital and on the helipad to take the patient directly to the OR. You want to definitely consider this for a patient that you have a known hemoperitoneum or positive fast prior to arrival. Bypass the ER. Or if you're going to go to the ER first, you're doing your trauma evaluation, but you're focused on making sure that the binder is appropriately placed. You may want to exchange that for a sheet and cokers and obtain your x-rays. You're going to activate MTP, obtain additional access, do your fast exam, and then REBOA consideration if unstable as a bridge to preperitoneal packing or IR. The positive fast patient and instability, that patient needs to be in the operating room, plus or minus REBOA in the OR or in the ER. There you will do your XLAP, your preperitoneal packing, your XFix, and then go back to CT or go directly to IR from there. Don't forget to do your separate incisions as we've been talking about. And if the patient has a negative fast, then consider OR versus IR depending on stability or the type of pelvic fracture or the hemorrhage pattern. Remembering that preperitoneal packing is going to target 85% of the hemorrhage in the presacral plexus. And that if you do go to IR, you need a efficient IR process. We talked about the delays that we always think we're going faster. We have we unlike many other centers use IR frequently, and very proud of our efficient IR protocols, and our IR guys are always there. But what's the ideal destination for this patient with an open book pelvic fracture and hemorrhagic shock? And that's the hybrid room. And that's what we've been talking about, where you can do everything. The REBOA, the PPP, the XFix, then IR or vascular can perform angioembolization, all in the hybrid room. Saves time, and time is blood loss. And the hybrid room really allows for flexibility depending on what the patient needs. In some centers, it's not always available during the day. Our institution has one hybrid room. I'm excited that in the future I'm working with hospital administration with a capital investment to get a hybrid room when we're building some more ORs. That's for trauma, but it is a strong consideration to use. So I'm just going to do a quick case review. I reviewed this case at our institution, and I chose this case not because everything went perfectly, but because it highlights several of the real life challenges and decision points that we've been talking about that are worth discussing. So this is a 40-year-old male who came as a distant scene call. The injury occurred 1.5 hours prior. MCC got a binder and got 1 unit of whole blood in the helicopter. On arrival was borderline hypotensive and hemorrhagic shock, a tachycardic at 160s, and also in respiratory distress, so competing injuries with bilateral flail chests. We had 2 units of whole blood in the bay, starting with, and then we activated MTP. So we resuscitated first and then intubated the patient and placed bilateral chest tubes. We performed a fast exam twice in the trauma bay. And I can't highlight the importance of doing that. Sometimes when you start to resuscitate a patient, their fast exam turns positive. This patient got a total of 5 units whole blood transfused in the bay, and this is around 10 a.m. So the only hybrid room that we have was in use. So this was what the x-ray looked like to begin with. A sheet binder is starting to be applied, and we didn't make much progress. That's the second x-ray. Third x-ray, still wide open, but a little bit better, and the fourth x-ray. So the heart rate came down to the 130s, and blood pressures were above 100 systolic, but still requiring blood. But the patient went to CT scan. This was the initial CT. You can see the mostly left-sided sacral fracture, sacroiliac joint disruption with hemorrhage. This is other cuts of that CT scan, mostly on the left there, and the wide pubic symphyses there. So this patient actually went to IR first as what we call as a category A response. Poke time was well under an hour, actually close to 30 minutes. And IR actually found extravasation, interestingly, at the right internal pudendal, right internal iliac artery was embolized, and the left obturator artery, and the arterial sheath was left in. And that patient went directly from IR to the OR, where ortho then placed an XFix. Unfortunately, the patient continued to require whole blood after the XFix and returned to IR after another CT a few hours later, where they then embolized the left internal iliac artery, which is not so surprising. So that repeat scan before IR showed that blood volume in the pelvis slightly increased, the XFix in place, as you can see, and XTRAV on the left. Interestingly, the CT cysto at this point in time demonstrated an extraperitoneal bladder injury as well. And on this other cut, you can see the 2 previous coils and the pubic symphysis now closed down with that XFix in place. Ultimately, the rest of this day, this patient received 13 units of whole blood in that 4 units of FFP, 2 BRBCs, and 1 platelets in that first 24 hours. And not surprisingly, this patient's hospitalization was complicated by rhabdorenal failure, CRT, went on to get spinal fixation, pelvic fixation, and rib fixation, and was discharged to rehab after 2 weeks. Things we did well: blood resuscitation and TEG-directed resuscitation. We did great. And time to IR and time to OR. But there are some potential things to consider in this algorithm. Consideration of using our REBOA as a bridge to either preperitoneal packing or XFIX or IR. The question mark of what about preperitoneal packing first? This patient was getting massively transfused and went to CT scan. And especially with that pelvis not closing down with the sheet binder, we knew that patient was going to need an XFIX sooner rather than later. And that CT scan, the first one, did not show any major blushes. The other question is, from the IR standpoint, either bilateral internal iliac artery ligation or embolization versus selective on the right, but going after the left. This highlights the importance of us as trauma surgeons being in the IR bay and talking with our IR colleagues because the main injury was on that left side. The other thing was that ultimately this patient did have an extraperitoneal bladder injury, and so that would have needed addressing had we done preperitoneal packing. Ultimately, this patient needed a trauma-specific hybrid room, which would have been a great option, would have given us more flexibility, and I'm excited that that will be in our future. Just so some take-home points: early decision to transfer, it's all about time. Rapid acceptance of those patients, early use of blood in the pre-hospital setting, preferably whole, avoiding crystalloid, avoiding time wasting with unnecessary CTs or central lines. And if the surgical capability at the outside hospital exists, considering preperitoneal packing and XFIX if they have it in an unstable patient, and then rapid and appropriate care of the hemorrhaging patient, both at the outside hospital and the receiving transfer center. Thank you guys so much.
Super. Thank you so much. We have a few questions in the chat, so I think we can move on to those. So Dr. Costantini, Dr. Scalea mentioned, the high mortality associated with these complex pelvic fractures that hasn't budged a whole lot, even at high functioning and high performing centers. Where do you see, from an education standpoint or a systems standpoint, where are opportunities to intervene and lower that mortality? Is this late death from multisystem organ failure? Is it concomitant injuries that are difficult to manage? Or is this the initial, management of shock and what we've been talking about throughout this session?
Yeah, I mean, my short answer is yes to all those things. I mean, these are severely injured patients that are at high risk, but I think what we can modify is time to hemorrhage control. And I think in many, Dr. Scalea nicely showed, and this is recent data from Malika Harfouch, who's actually using angioembolization versus pelvic packing. Everywhere people have a predominantly angioembolization only approach. And while some centers like Dr. McCauley's can do that very quickly in a half hour, many centers can't. And I think that to me is where the opportunity lies, is can more centers become facile with doing REBOA earlier to bridge that time? Or if not, should they go directly to the operating room as a first step? So I think continuing in the same angio first approach is probably not the right thing, because we'll continue to have the same outcomes that we've had forever.
Yeah, I would say it just depends. You work where you work, and you need to fit your solutions to what you have. And it's important, I think, to be critical in your assessment of what it is you're doing. And I'll give us points for publicly admitting we weren't very good in 2015, but then we changed it. And I think it's, people think they're doing better than they are. And you need to really cone down and fit your solution to where you live. What we can do can't be done other places. What other people can do can't be done, down the street. You fit it to fit your level of expertise, and resource availability.
Yeah, absolutely. Kind of jumping off that, if places, for example, like we put in a REBOA maybe every few months, should we focus our training on that? Should we, really try to utilize that and that femoral first approach for these sick trauma patients? Or should we focus on other aspects of our care, right? I think you showed the graph of 4 or 5 trauma centers who are high volume with and very facile at that procedure. For other centers or the centers Dr. McCauley is working with, should those centers be focusing on REBOA use or other adjuncts?
Yeah, maybe, but it's about investing the time to make it part of your daily routine. And it's not just the surgeons, right? The nurses they have to get it set up. And if they don't, you guys need to know where it actually sits. You're running around trying to find the kit. None of that works very well if you invest the time so that it is automatic, whether you're training on the simulator or you're using it clinically or something. Then I think REBOA it's made for pelvic fracture bleeding.
I agree. You just can't wait for only pelvic fractures to come to your center that need it a couple times a year and then think you're going to figure it out. It's never going to happen.
So I think we have time for 1 or 2 more questions. The next one is there, and this is to anybody, anonymous. This was anonymously asked. Has there been any literature on REBOA use in the pre-hospital setting?
Not very much. The United States are I guess the military in general, they have a clinical practice guideline and have used in Iraq and Afghanistan, they have used pre-hospital REBOA. There have, in Europe, where they have physicians on board pre-hospital REBOA, that was the UK trial, the pre-hospital REBOA trial. And so I think it's certainly not very common. And I think you really have to ask the question, do you want to spend the time playing with the REBOA out in the field as opposed to driving or flying fast?
Yeah, the idea of a REBOA in the rural austere settings like ours gives me heart palpitations because we already have an issue with time and getting these patients to us, and then we have issues with tourniquet time, and so then we're going to have the other side of the coin is ischemic legs. So it's a really interesting question where to use a pre-hospital REBOA. We'd have to do a lot of research on that.
Well, if you think about the number of pre-hospital providers you've got and the number of REBOAs they're going to put in per year and what it's going to take for them to maintain competence and it gets a little hard to develop intense enthusiasm for that.
Yeah, I'll just add we don't deploy this well in 90 or 95% of level 1 and 2 trauma centers. Why do we think we're going to be able to do it in the sort of pre-hospital or non-trauma center setting?
Yeah.
Yeah, absolutely. Well, it looks like we are 1 minute past the hour. I want to thank our speakers, Dr. Scalea, Dr. Costantini, Dr. McCauley. Thank you for a lively discussion and such an important topic. Appreciate everyone's time and expertise today. Everyone have a great rest of your day. Thank you.
Thank you. Great session.
Thank you, everybody.
Thank you.